face is sharp, but you still see around this space around. You're using the peripheral vision with the periphery of the retina. What is age-related macular degeneration? I think the name itself tells you the story. There are three players here: age, macula, and degeneration. So it's pretty obvious. It's age-related, means that it comes with age. Possibly we get older, we expect to see more macular degeneration. So this disease involves macula. Now you know what macula is and what macula does. And this is degeneration there. What does degeneration mean? It means breaking down very slowly. It means wear and tears, getting worse very slowly, gradually, and losing the function over time. So what happens in macular degeneration? You are going to develop some deposits right here, right inside the macula. These yellow spots inside the macula, we call them drusen. So what are these? They're basically some junk, wear and tear, 50, 60, 70 years, cholesterol, some proteins deposit inside the macula. The macula on the other picture I showed you, that was a normal macula. It's shiny, nice, smooth. This one is bumpy, and there are some junk inside it. Now we're going to talk about the stages of macular degeneration. Because I'm going to tell you what to expect or what the patient would see in each stage. There are three main stages: early, intermediate, and advanced. Early stages, you see few drusen in the back of the eye, very small ones. And look at this line, this green line is a cut from this line. And this is called OCT image, is basically similar to MRI for the eye. So if we cut it from here like a cake, but flip it 90 degrees, looking from the side, you see this image here on the right. You see there are few small bumps in the back of the eye. This is early stage. There's no symptoms in this stage. So that being said, you may have macular degeneration, you have no idea. It doesn't cause any pain, doesn't cause any tearing, no red eye, nothing. Symptomless, you may have macular degeneration. Then we go to the next stage, which is the intermediate stage. You see these bumps are bigger, these yellow spots, we call them drusen, are larger. So what to expect at this stage? What does my patient says to me when they come to the visit? We're going to complain about visual distortion. These lines here on this grid, we call it hemisphere grid, they're going to look wavy to the patient. How it's going to impact their life and lifestyle? Imagine this one. This is very exaggerated type of image to understand. So the lines become wavy. When you try to read, it's going to look like this. Some letters are spacing out here, some others are crumping to each other. So it's going to be really difficult to read, or something like that. In advanced stages, those bumps would go away, and it's going to leave some scars in the back of the eye. See this yellow kind of round spots here? This is a different type of image, shows you what is missed in the back of the eye. See, these are normal. This color here is normal, but right at the center inside the macula, there are some dark spots here. Dark is not good there. It means that these spots are dead. We call it geographic atrophy. You may have heard of that. There are lots of advertising on the TV for drugs for age-related macular degeneration for geographic atrophy. This is what it is. How it's going to impact patients' vision? This will happen to the eye. So that amazing picture, you go to the beach, you want to see the ocean, it's going to look like this. So there are some dark spots right at the center of the eye. At this stage, many people may give up driving because they cannot see. It's not safe for them and for the others, of course, to drive. These are all dry macular degeneration. So we have another term called it wet macular degeneration. You may have heard of that. What's the difference between dry and wet? This is a patient I saw last month. This patient has some of those advanced stages. You see, it's these dead spots here, some dead spots here, geographic atrophy. Patient calls and hey, overnight my vision got much worse. What do you think has happened? This image is now this one. Why? Because there's a lot of hemorrhage right at the center of the eye. So in advanced stages of macular degeneration, this layer is thinned out, and this blood vessel under the retina that can penetrate coming inside and cause a lot of hemorrhage in the eye. That's what we call wet macular degeneration. The word, the term wet comes from the blood or exudation or fluid inside the back of the eye. Okay, I guess I freaked you out a lot. You want to know how common is that? Are you at risk or not? Fortunately, it's not that common. It's not like diabetes that is very common, okay? And again, it's age-related macular degeneration. If you're younger than 50, you're probably safe for now. If you're older than 80, the chance goes much higher. But look at this one. Macular degeneration is the leading cause of visual loss in people who are older than 60 in the US. So if you know someone who's older than 60 and they cannot see well, possibly that's macular degeneration. How can we, how AMD can be prevented? Can be prevented? I think that's a fair question after all of these things I told you. The fair answer is that no, we cannot prevent macular degeneration entirely. And it's pretty obvious. I'm just keep saying age-related, age-related, age-related. If you can stop aging, of course, you can stop macular degeneration. You can prevent. If you stop aging at age 50, I promise you, you're not going to get macular degeneration. But it comes. But what we do is to delay those changes in the back of the eye, going from that earliest stage to advanced stage, going from dry to wet, which is wet is not good. This is my most important slide, okay? Most of you, I believe you don't have macular degeneration, most of you, but you wanna know if you're at risk, getting older, how you can prevent macular degeneration, how you can delay macular degeneration. Because I said there's no cure for it. Number one, do not smoke. Smoking is not good for macular degeneration. Not good for many things, especially macular degeneration. Your chance will be 2 to 4 times higher when you smoke. Number two, eat healthy. Diet full of green veggies and antioxidants. You're gonna ask me what to eat, what not to eat. Okay, anything leafy and green vegetable, that's amazing for macular degeneration. Like kale, broccoli, spinach. They're great for macular degeneration. Some other studies recommended Mediterranean diet. That's why you see that fish and that olive oil over there. So combination of these, Mediterranean diet also has a lot of veggies in it. What else? Antioxidants, all of these nuts. Nuts are so good, they have a lot of antioxidants. The kale, the broccoli, spinach, as I said. Unfortunately, I don't see kebab kubide here that we serve tonight. That's a bummer. I don't know closest things to that, and maybe Ormasati has some green leafy vegetables. We didn't serve it tonight, we're sorry, but enjoy tonight, tomorrow when you're home. If you want to fight macular degeneration, just splash some olive oil on this salmon, put this in the air fryer. In the meantime, steam up some of these broccolis and go for it. That will be the best food for macular degeneration. This type of lifestyle and diet can reduce the risk of AMD 30 to 40%, which is a very good deal for a disease that you don't have treatment for. And protect your eyes from UV light. You know, those sunglasses, they're not for fashion, okay? Use them. It protects your eyelids from a cancer. It protects your eyes from macular degeneration, and also progression of the cataract will be slowed down with those sunglasses. And stay healthy and maintain healthy. There's multiple studies that show that if you are overweight, if you have hypertension, if you have cardiovascular diseases, you have you have much higher risk of macular degeneration. So again, I'm going to go over it one more time. Do not smoke, eat healthy, protect from UV light, and stay healthy. These are the things we can change. I can choose what to eat, what not to eat, okay? But there's some other factors we don't have any control over, unfortunately. Number one, what do you think is that? It's right. Age. We cannot stop aging, so age is the main risk factor, even worse than smoking, okay? Age is the main risk factor that we unfortunately cannot control. What else? Our genes. So we start with our genes. We cannot change our genes. So 50% of the macular degeneration comes from our genes. That being said, 50% we don't have any control of, but 50 other percent is the lifestyle. If you change your lifestyle, at least you can control that 50%. And especially this is for those who have some risk factors for macular degeneration. Like if you are smoking and you have bad genes, okay, you're doomed. Do not do that. If you have bad genes in your family, if you have family member with macular degeneration, take care of those modifiable risk factors and eat healthy, stay healthy to prevent macular degeneration. Very briefly about the treatment. Dry macular degeneration, I said there's no cure for it. So when I see a patient, I tell them everything I just told you guys here. Lifestyle changes for the patients. We have some vitamins for the eye that people with macular degeneration can take. But I put this in purpose here because everybody's picking up the phone, take a photo to buy it from Costco. Do not buy this if you don't have macular degeneration, okay? It does not prevent macular degeneration. Couldn't be clear, more clear, okay? It does not prevent macular degeneration. If you do not have macular degeneration, do not take this. If you have a family member who want to prevent macular degeneration, do not take this. It's been already studied. It does not prevent macular degeneration. But those lifestyle changes, those take care of the macular degeneration. What do we do for wet macular degeneration? We do some eye injections, okay? That injection goes from the white part of the eye inside that vitreous cavity. We inject the medication inside the vitreous and it goes to the macula and stop bleeding. It's a very common type of treatment. It's not scary, it's painless. We do this a lot. I was in the clinic this morning, I don't know, I did maybe more than 20 injections this morning. It's very common these days to do that. This is my last slide. Let's go over some facts one more time. You're not gonna go blind when you have macular degeneration because it's macular degeneration. It involves your macula. But the rest of the eye, you're gonna preserve that. So it's not like you cannot find the way to the bathroom, it's totally dark or something like that. No, you still have that, which is amazing. Doesn't have any symptoms in early. Sometimes I get really surprised in the clinic. Patients have wet macular degeneration, they have no idea. They never covered this eye to figure out the other eye is not seeing at all. Or as I said, early stages, intermediate stages doesn't have significant symptoms. That being said, if you are at risk, if you are older than 50, 60, if you have a family member, have your eyes checked for macular degeneration. I know many of you guys go to your optometrist once a year to check for glasses. They do not check you for macular degeneration most of the time. Ask them to specifically check you for macular degeneration, take a look at your macula. And I hear this from my patients time to time. When I was a kid, I did that or this. When I was young, I read a lot of books or something like that. No, it's not coming from this. So if you read too much, do a lot of sewing or something, it's not going to cause macular degeneration. Again, those eye injections, they're not painful. So if you have a family member, you hear it in a party, someone says, I get the eye injection, cheer them up. Don't say, oh, بیچاره, oh, خیلی از این درد داره، الان چجوری کدومش از این تجربه داره. Help them, please. Again, there's no cure, but there's a lot we do. The wet macular degeneration, we have amazing treatment for it. We can dry it out again. And there's a lot of lifestyle changes as we talk to delay macular degeneration. And I see the future is very bright. Every year there's new advancement. We have something new. We have light therapy these days. We have treatments for dry macular degeneration. We never had treatment in the past. There's a lot going on, so it's not hopeless at all. Thank you for your attention.
Please keep your question for at the end for all three of it, just to move around as is scheduled. The one thing I forgot about Dr. Ruzani, he's graduated from University of Miami and eye education in Bascom, which is a very famous national actually. So, I'm sorry. And second one is Dr. Kuzikanani, that I have privilege to know him for a while. Dr. Kuzikanani actually graduated from University of Wisconsin, right?
Fellowship at the University of Wisconsin.
Fellowship. And the other one was Cincinnati, right?
No, Medical College of Wisconsin Fellowship, University of Wisconsin Residency, and then Ohio State.
Anyway, Dr. Kuzikanani is practicing in two places here in Minneapolis, University of Minnesota, and also one day a week. Am I correct? We call it retinal clinic. He's really, I have to tell you, I have watched him how he works. Quite skillful, really, and very up to date. So with that, any question from you two, please keep it to the end, and we go from there.
All right, thank you for that lovely introduction. Too kind. My presentation is called Flashes, Floaters, and Attachments. Oh my. If you've seen The Wizard of Oz, you'll understand the reference. Otherwise, ask someone to explain it to you, I guess. So imagine this scenario. You're a care provider, anything other than an ophthalmologist. Could be a podiatrist, dentist, some other type of specialty of physician. And you're seeing a patient for some completely different reason. And as they're leaving, they have their hand on the door, they say, oh, by the way, I've been seeing flashes and floaters recently. Do I need to worry about that? So what do you tell the patient? You tell them, don't worry, just ignore those symptoms, they'll go away. You tell them to go to the ER immediately or to see an eye doctor. And if so, when? Tomorrow? Sometime in the next few weeks? Or months even? So the goals of my presentation is to help you understand what causes flashes and floaters, to know the appropriate management of flashes and floaters, and to understand why there's a concern for retinal detachment with flashes and floaters. So Dr. Ruzbahani was very thorough in his eye anatomy. I'll just hit the highlights. As you recall, the eye is a hollow ball filled with vitreous jelly. When we look into the eye, we're looking through the pupil into that space, and the inside is lined by a thin membrane called the retina. And that's the part that senses light, and the macula is the center of the retina. So that vitreous jelly is not just some amorphous, uniform liquid that fills the space. It actually has structure. It's actually a formed mass. And here we see the vitreous jelly of a young person who unfortunately had their eye removed and dissected out, the vitreous was, and you can see it's actually holding the shape of the eyeball even without the rest of the eyeball there. This is in a young person, of course. And that shape, that's because it has a structure. It has collagen fibers that run from the front of the eye to the back of the eye. Those collagen fibers have a relatively weak adhesion to the optic nerve and to the macula, the central retina, and a very firm adhesion to the front of the eye, just behind the iris. We call that the vitreous space. Now, as we age, those collagen fibers kind of coalesce and clump together, come out of solution essentially, and form little opacities, and then the liquid gets squeezed out. And those opacities move around and cast shadows on the wall of the eye, and that's what we call floaters. And lots of people have floaters. Sometimes they're a series of little dots, sometimes little strings, either dark or bright, sometimes clouds. They're quite common. But what happens over time is as more and more of these collagen fibers come together and condense and the liquid portion gets separated, the volume of the formed vitreous gets smaller and smaller. And eventually the posterior surface of the vitreous jelly pulls away from the back wall of the eye. When that happens, we call that a posterior vitreous detachment. And this picture here kind of shows what's going on. You can kind of see the back surface of the vitreous has separated from the wall of the eye. It's actually a very common thing. About 2/3 of people have this happen by age 70. And most patients have no symptoms whatsoever. They're none the wiser that this has occurred. But sometimes when this happens, those opacities in the jelly, they move around more, the shadows are more apparent to the patient, or there might be particularly prominent condensations of the vitreous fibers where it had been stuck to the optic nerve or the macula, and the patient may notice these floaters all of a sudden. Sometimes the vitreous jelly can have a little adhesion to the retina that creates a little traction as it's separated. And patients may experience that as flashing lights. There's no pain fibers in the retina, but this traction does stimulate the light-sensing cells, and so people see flashes of light. Let's see, hang on. I think my thing's auto-advancing, sorry about that. And as the vitreous jelly is moving around, it kind of disperses the light a little bit, and sometimes patients notice a mild haze or blurring, loss of contrast with the PVD. The emphasis there is mild, not a severe loss. So these floaters that people see can be very, very bothersome sometimes. Mostly they're a mild nuisance, but occasionally they're very bothersome. But they usually get better in 6 to 12 months. That's what I tell all my patients. And it's true for the vast majority of patients, both because the floaters may move so that they don't cast shadows that the patient notices. They kind of move away from the central vision area. And people just get used to them. The brain just filters them out. And so usually by 6 to 12 months, patients aren't much bothered. If that fails to happen, there are interventions we can do to treat these floaters. It can be as simple as a low-dose dilating drop, which increases the light in the eye, and that makes the floaters less visible. You can use a laser to basically break the floaters apart or partially liquefy them. That helps make them less noticeable. Or you can do vitrectomy surgery where you actually remove the vitreous jelly and the floaters with it. That being said, floaters aren't harmful, more or less, and though they can be a nuisance, and vitrectomy surgery or laser can have risks. Bad things can happen from the surgery. And so generally we're conservative about doing that. Most retina specialists only do that in more severe cases. Need to get rid of the auto timing. Anyway, so the concern with the vitreous detachment is that you can have a retinal tear. And so new floaters and flashes should be referred for an eye exam within a few days or weeks after onset. And the urgency is more if there's a history of trauma, if the patient has lots of floaters, or if the vision's actually decreased more than just a little bit, if it's actually substantially decreased. Those are all red flags, but they need the more urgent referral. So this retinal tear that I've been mentioning, it's a risk with any PVD. It's about a 1% risk with any PVD. And what happens is, as you recall, I said sometimes the vitreous can have an adhesion to the wall of the eye, to the retina. And as it's pulling, instead of separating, it actually rips the retina. And then the liquefied vitreous jelly from inside the eye can go through that rip and actually separate the retina from the wall of the eye. This happens to a large extent we call the retinal detachment. So the risk of a tear is about 1% of any PVD, and that can be any time within the first 3 months after it comes on. But there's a substantially higher risk if you have symptoms from your PVD, about 10% at presentation, and an additional 3% risk over that 3 months afterwards. And if we catch this early, that's our goal. We want to treat this before it leads to a retinal detachment. And so if we catch this early, before any fluid has gone through or before very much fluid has gone through, we can treat with a laser in clinic. This shows conceptually what we're doing. We're shining a laser through the pupil and basically creating a ring of burns on the retina around the retinal tear. And that creates a firm adhesion of the retina to the eye wall and prevents the retina from separating and prevents fluid from being able to collect there. This other picture shows how we do that in the clinic. With the head-mounted laser, that's one of a couple of techniques we've got. It's a pretty tidy technique. It's done in the clinic, usually under very little, if any, anesthesia. It takes about 10 to 20 minutes. And the success rate is about 80 to 90% of needing any other interventions. Now, the reason why you might need other interventions, despite the laser, is that, as you recall, I said that this window of 3 months where tears can develop, but you might develop additional tears during that 3-month period. The floaters and flashes of light that you have don't go away after we treat the tear. You may form fibrous tissue on the retina, what we call an epiretinal membrane, which can affect the vision. And it's extremely rare, but it is possible to accidentally damage the macula with the laser, but thankfully that's extraordinarily rare. Now, if this isn't treated promptly, or there's some delay for whatever reason, the patient didn't have symptoms, you can get a retinal detachment. That's where a large amount of fluid collects under the retina, and a large portion of the retina separates. And here we have a picture of the patient with a retinal detachment from the clinic. This area that looks kind of funny here is the detached retina. There's actually several holes. I'm hoping you can see my mouse on the screen. I guess you can't really. Hang on. I apologize for the auto advancing. So there's kind of lighter areas in the upper left corner of that detached area. Those are multiple retinal tears in this patient. So these detachments are typically repaired in the operating room in the U.S., either with scleral buckle or with vitrectomy surgery, or both. Though they can be treated in the clinic with pneumatic retinopexy, which is a procedure that's very popular in Canada. If you don't treat a retinal detachment, more and more of the retina will separate until basically all the retina is separated, and you will go completely blind from this, irrevocably, so if you wait too long. So to explain how these repair techniques work, I'm going to start with pneumatic retinopexy. Basically, you inject a bubble of gas into the eye. There's different gas mixtures we can use. And the goal is to achieve about a 30 to 50% fill with the gas. And then the patient positions their head so that the bubble basically floats in front of the hole and blocks it off. And with the hole blocked off, and they have to do this for several days. And with the hole blocked off, fluid can't go under the retina anymore. And in that situation, the body actually absorbs the fluid, as almost no new fluid is coming in. And so within 1 or 2 days, there's no fluid under the retina, and you can use a laser, kind of like I showed in the earlier slide, to seal the hole to prevent any more fluid from going through it. And the gas bubble actually dissipates on its own within 1 to 2 months, depending on what particular gas mixture you use. And so this is a pretty nice procedure. It can work well. Because the patient has to position to place the bubble, over the hole, it doesn't work well if the hole is, on the bottom half of the retina. Scleral buckle surgery is another technique that we use. This is where we take a plastic band, and that's what we use now is a silicone plastic. And we basically tie it around the eye, cinch it like a belt around your waist, and the goal is to indent the wall of the eye. And the idea is that if there's traction on the retina is being torn and pulled away from the wall of the eye, maybe you can solve the problem by pushing the wall of the eye in towards where the retina is. And this actually relieves the traction. The flap kind of closes during that process. No more fluid goes through, and then the retinal detachment dissipates on its own. And this procedure works very well also. And this shows, some pictures from a surgery that we did, where we basically took this plastic band, the silicone band, and you can see how we threaded underneath the muscles, and you can see we're on the other side how we're placing the suture to kind of hold it in place. And so it's a surgery that works very well as well. I should have given a trigger warning. I'm going to be showing some surgical pictures. I hope no one is traumatized by these. The more popular technique in the US is vitrectomy surgery, though. This is where you actually go inside the eye, and we have 3 ports that we use. One for a light, so we can see what we're doing. We're looking directly through the pupil to visualize what we're doing. And one for an instrument that we call a vitrector, as well as other instruments. And the idea is we basically remove the vitreous jelly, and while we do this, there's a 3rd port that keeps the eye inflated while we're doing this so it doesn't collapse. We remove the vitreous jelly, then we remove the fluid that's underneath the retina. I'm going back and forth because that's auto-timing, so bear with me. We remove the fluid that's underneath the retina, and then we fill the eye with a bubble of gaseous mixture, and we laser the hole as before, and this time we get a very large gaseous hole. The eye is mostly filled with gas. And both of these surgeries, rather, are outpatient surgeries. It can be done either under local anesthesia with sedation or general anesthesia. With a bubble in your eye, there are some restrictions. You can't travel over high altitudes or fly in an airplane because of the air pressure difference. There's certain anesthetics you should not get. The bubble blocks your vision, and so you won't see very well with a bubble in your eye. And there's the matter of face-down positioning. Patients hate face-down positioning. That is the one thing that they always remember. If you want to know if they've had this surgery, ask, did you have to be face down for a few days? That's what people always remember. And basically the idea is we need that bubble to float to block off the hole so that the laser scars can form firm adhesion. And usually when we've done a vitrectomy, we need them to be face down. And this shows how you might achieve that while awakened, while sleeping, with some special positioning pillows while you're sleeping. You can take a brief break for a few minutes, to eat, go to the bathroom, that sort of thing. But patients really find this very uncomfortable for obvious reasons. So retinal detachment surgery works very well. About 80 to 90% success of fixing the retinal detachment. Pneumatic works really well as well, slightly lower, about 70%, but still pretty well. Unfortunately, about 10 to 20% of the time, people get recurrent detachments. For one reason or another, their retina detaches again. And retina detachments are a very bad problem because they can cause permanent vision alteration or loss, even with one successful surgery. The detachment itself damages the retina. And if you require repeated surgeries, then that damage is even more likely to happen. You can get an epiretinal membrane, which is that scar tissue we talked about. You can get swelling of the retina and double vision. But with surgical techniques, the results are relatively good. If the macula is not involved in the detachment at all, we call it a macula-on detachment. About 90% of people maintain driving vision at 10 years. Maybe not as good as it was, but still good enough to get a driver's license. And if the macula is involved, 2/3 of them, 65%, still maintain vision good enough to drive. And so last, I have a quick video of a scleral buckle with vitrectomy surgery that we did not too long ago. This kind of will show the surgery. It's massively sped up and heavily edited. We kind of open up the conjunctiva. We kind of grab the muscles that move the eye around, move them with silk. And then you can see how we're threading the buckle around the eye on the outside, wrapping it around and cinching it tight. We're placing sutures to hold the buckle in place. Kind of partial thickness sutures, and then we place those ports that you saw to kind of enter the eye. This shows the infusion in the 2 ports, and then we use a special lens system to see what we're doing. You can see the light and the vitrector. You can the detached retina of the lighter color retina on the front. We're removing the vitreous jelly, kind of trimming the peripheral retina vitreous there. We actually are draining the fluid from underneath the retina through a hole. We're filling the eye with a bubble gas air mixture, draining more of the fluid, and now we're doing the laser. Again, this is massively sped up, just so it doesn't take too long. Then we remove the ports, sew things up, close it up, and it almost looks like it did when we started. You can hardly tell we were there.
Do you want to tell people that you do it?
So, sorry?
Do you want Do you want to tell the people you do it under IV sedation and local anesthesia versus general? I have seen that you guys do it.
Yeah, we can use usually local or general.
Thank you very much. Well, and the last speaker is, first of all, with spelling in English, I called him a little bit different, and thank you for correcting me. Dr. Nazari is newcomer from our country, Iran. His original medical training and fellowship and ophthalmology training was in Tehran. He graduated from Medical School of Zanjan, and he was the faculty. Dr. Nazari is a newcomer from our country, Iran, although been here for several years. He graduated from medical school from University of Zanjan, and please correct me anywhere. And then he did ophthalmology and retinal fellowship there. He became faculty actually in the places that I used to be faculty there too. دانشگاه علوم پزشکی, if you heard of it. Our medical school was part of that. Anyway, Dr. Dr. Nazari actually is from Tabriz, where my wife has 25% of his gene from that city. And then he doesn't have any disclosure. He's going to talk for the rest of it, and please keep your question to the end. Anything else you want to add?
No, my story is long, so.
He works in the University of Minnesota, and I heard that he worked one day with Dr. Mihan-mn. Right. Okay.
Thank you so much, Dr. Hosseini, for a kind introduction, and thank you, Mihan, for organizing this wonderful event. It's really a privilege to be here and meet you all. I didn't have the privilege of knowing some of you, or number of you. I am looking for the opportunity at the end to meet you and just get to know you. So enough of diseases of old people. Let's talk about diseases of young people, like all of us. I'm going to talk about diabetes and diabetic retinopathy and how to prevent going blind from it. I've organized these in 5 steps. So diabetes, most of us know, is a metabolic disease of high blood sugar for a long time. It has type 1, there is no insulin. Type 2, there is insulin, but there is a resistance to insulin. And then diabetes happening during pregnancy. People have known this for a long time. Even in Egypt, centuries or millennia ago, they have talked about the disease that they drink a lot and they pee a lot and they lose weight. Probably about diabetes they were talking. But then look at this. This map is from a few years ago. 460 million people have diabetes in the world. 1 in 11 adults, and then this number is not. This number is increasing in the world. In the next how many years? 20 years, 50% increase in the number of people with diabetes. Here we are privileged. In the US, we have all these resources in our disposal, but we are also going to see 30% increase in the rate of diabetes over the next 20 years. In this little, our little kitty, our beloved country, Iran, with that region, the rate of diabetes is going to increase 100% in next 20 years. So look, let's look at Minnesota. So Minnesota, we are not too bad. We are not one of those red, dark red colors, but we are still, 10 around close to 10% rate of diabetes in our state. That translates to close to 500,000 people in our state with diabetes. We are spending billions of diabetes. In the US alone, 327 billion, and this is from a few years ago, spent on diabetes, direct and indirect costs of diabetes. All right, so what does diabetes do to our body? In brain, many people with diabetes, eventually they get strokes. Heart, they get heart attacks. 20% of adults with diabetes get heart attacks. Kidneys, we all know people with diabetes who go to dialysis. Nerves, they get busted, neuropathy. A good percentage of people, paresthesia, numbness, or tingling of their fingers and their extremities. Diabetic foot, a lot of people end up with amputation. 25 times more chance of amputation in those who have diabetes. And this is a hefty number of increasing the rates of all these complications. And then when it comes to the eye, this is the most common cause of blindness in adult, working age adults, so young people like us. All right, so what does, then let's talk about the diabetes and the eye. Vision loss from the diabetes is on the rise. One in 3 person with diabetes is gonna end up having some sort of diabetic retinopathy that can lead to blindness. So how diabetes can affect our vision if we get diabetic retinopathy? So we can get changes in refraction, we can get more nearsighted or farsighted, cataract, dry eye, retinal edema, we'll talk about those, and retinal ischemia. Then everything becomes blurry, we cannot see well, even with glasses. But it's not just that. In more advanced stages, we can get hemorrhage, bleeding in the eye, and then world looks like this, how you see here. It blocks and patches of darkness in our view. Or we can get retinal detachment from diabetes. Part of the world will start becoming dark and dark and dark, and then it reaches the center. Or glaucoma, we get our peripheral vision lost over time. So this is a busy slide, but since most of us are healthcare professionals, included this, but we don't need to focus on all of these. It's just that diabetes starts affecting small vessels with from oxidative stress and inflammation. Then vessel walls change, microaneurysms happen, leakage from vessels happen, then bleeding happens in the eye, in the retina, in the retina and inside the vitreous cavity that Dr. Kushanani and Dr. Rozbahani showed you. Vessels can get occluded, and then abnormal vessels start to grow. What do all these mean? So this is what that means. This is what happens in the eye. So you saw similar pictures. So to the left is normal retina. Up is a cartoon, and then the bottom is just normal picture. When we examine patients or when I take pictures, I see normal eyes. I'm not going to go through all these details of the small parts of anatomy in the eye, but then looking at the right side, these are what happens in diabetes: hemorrhages, abnormal vessels, leakage, lipid deposit in the retina. That all of these can lead to blindness. So this is how I see a patient with diabetic retinopathy. Leakings here and there, deposits here and there, and then more advanced stages. Here you see that all these vessels coming off towards you. These are abnormal vessels growing from the eye nerve, ready to bleed, and patient can lose vision like this. He is actually a computer engineer, software engineer somewhere in Twin Cities a few years ago. So you see those, you see that network of vessels, they bled, and he lost vision overnight from just normal vision to 2400 or something. So what do? We take out all these examinations, and we take pictures, and then fluorescein angiography is one of the modalities we use to see how these vessels are. In normal eye, you see this galaxy form of lines is fluorescein angiography and are normal vessels. But then in diabetes, what happens? We lose these vessels in the form of capillary dropout. You see all dark. There is no background of grayish, whitish normal flow. It goes dark, and then we get abnormal vessels in those bright white, or small the dots of white. These are microaneurysms, so changes in vessel walls. And then what else we do? Again, you saw these pictures. We take cross sections from retinal. This is how normal retinal look. So all these nice layered structure, like a birthday cake, is our normal retina. We should have a central dip nicely right at the center. But this is a retina from a patient with diabetes. All leakages accumulate there. Retina becomes thickened, and we lose that central dip. Now we have a hill right at the center of our vision. This is not good. So as you saw in those other pictures, people lose their vision. Things become blurred and they cannot see well. Then we have more newer modalities, OCT and geography. I'm not going to go through this, but I'm just showing you that retina is in layers, that has layers, the vessels in layers. This picture bottom of this video is from one of my mice when I was doing more basic research. I stained the vessels and then and some of their nerves, showing how these vascular layers are organized, and then we can lose them in different diseases, including diabetes. Now that I've convinced you, hopefully, that diabetes is bad and we can go blind from it, then let's see what steps we can take to avoid that or prevent that. So the patient comes to me, hey doc, I don't want to become blind from diabetes. What should I do? Don't get diabetes. Simple. So don't get diabetes. So what to do to don't get diabetes? Lifestyle modification. Cut sugars, eat low carb, high fiber diet. Watch portion size. So I like this cartoon here. So it says Billy has 32 candy bars. He eats 28. What does he have now? He has diabetes. So don't think about the numbers. Billy has diabetes. Minimize intake of processed food. So processed foods are not good. So my better half here, Farishta, is sitting there, my wife. So she keeps me on check. And good, healthy diet, Iranian diet, Tabriz version of the diet is healthier. But then, just to be fair, all Iranian diet is good in moderation, right? So not kebab 2, 3 back to back. Or kufte. Kufte. Okay, you got me. All right. Yes, kufte is the only thing. Too much is bad.
It's from Tabriz is okay, right?
Yes, but yeah. So, Nazan got me here. Thank you. Anyways, food in moderation. But then again, to be fair, Mediterranean food, where Iranian, Arab, Turkish food are from the same region, same type of diet we have. These are healthy. These are better than processed food that are rampant here in the US. Instead of colas and sugar, drinks and juices, drink water, tea, coffee as your main beverage. Get more physical activities, exercises, lose extra weight, stop smoking. So these are the steps to the life modification that you can do to prevent diabetes and prevent losing vision from diabetes. So patient comes back and say, hey doc, I have diabetes. What should I do not to get, lose vision from diabetic retinopathy? All right, don't get diabetic retinopathy. Even if you have diabetes, you can stop getting more advanced form of diabetes in the eye, diabetic retinopathy, and losing vision from that. So what should we do to not to get diabetic retinopathy? Risk factors of diabetes we should know, and we can modify those. Longer duration of diabetes. If you have diabetes for the last few years, probably there's a good chance that you don't have diabetic retinopathy, and then you can have better chance to control your diabetes and not to get to that dangerous or dangerous levels of diabetes that can cause blindness. Good blood sugar control, blood pressure control, having good lipid levels, anemia, proteinuria, pregnancy. These are all risk factors for getting diabetic retinopathy and losing vision from diabetes. So these are two great studies, DCCT and UPDS. In 1990s, they showed that if you have diabetes and you have a good control of diabetes, you can really prevent side effects or complications coming from diabetes. Look, in type 1 diabetes, those who had intensive control had over 9 years, how much less they had complications of diabetes in contrast to just conventional, just a little bit of control. But then in type 2, again, if you have a better control, tighter control of blood sugar, you have less death related to diabetes, less myocardial infarction, stroke, and diabetic retinopathy, and so on and so forth. So one thing that is, just fairly new, and it's called third revolution in diabetes control, is these continuous glucose monitoring systems. So you've probably seen people wearing these Dexcom and Freestyle Libre. Again, showing that those who have tight control and continuous control monitoring of diabetes, they have much less ED visits, other doctors visit, and losing vision from the eyes. Now I'm not going to play that dark joke, so I'm going to just go ahead to the third step, which is if you are getting diabetic retinopathy, find it as soon as possible. You can have diabetes for many years and starting to get diabetic retinopathy, but if you don't pay attention, it can be catched early on. So you want to get screening for diabetes. See your eye doctor, have them check your retina for diabetes. So, and this has to happen every year. Now I'm going to show you when and how often it needs to be done. But it needs to be done as a dilated fundus examination, as Dr. Uzbahani mentioned. So you can get your eyes checked, but then they may miss looking at your retina. So just ask your doctor to look at your retina, and if there's any signs of diabetes, have them send you to an specialist. So if you have type 1 diabetes, they present early, so you don't need to get your eyes checked early on. So within first 5 years, if you get your eyes checked, you are in a safe place. And then after that, every year. If you have type 2 diabetes, there's a good chance you've had diabetes for a long time before a diagnosis, then get your eyes checked immediately and yearly after. This is a busy slide, but I just want you to bring your attention to this red box that shows, some people really need once every month or every 2-3 months examination. So it can be that intense examination for diabetes. Referral criteria: if there's no diabetes, our optometrist colleagues, they don't need to refer patient. They can keep examining the patient, or a comprehensive general ophthalmologist. But then if they have any sort of diabetic retinopathy, better to get those patients sent to a retina specialist to be seen and to be treated accordingly. So how then we have our telehealth and AI specialists here. Mehdi, I just had the chance to know him for the first time. So yes, so now this is a big thing in our field, and especially for the diagnosis. And many of these cameras are now installed in primary care physician offices, and then in even in sometimes in malls also you can get these installed, and then AI can make a diagnosis for you. And if you have diabetic retinopathy, you can be referred. So this handheld camera, and there are a few of these, got FDA approval a few years ago, and their AI the system can make a diagnosis of diabetic retinopathy and trigger that referral to a doctor. And then over the last few years, cell phone fundus photography, that you can just with a of course it needs special tools or just education and practice about that. With a simple smartphone, you can take a retina picture, and then of course a retina doctor needs to see those, or an ophthalmologist. So I published about these in 2017, fundus photography with the cell phone, and then our focus was at that time about the diabetic retinopathy. And more recently with my PhD student, we looked at the handheld cameras, and then their applications in healthcare, including diabetic retinopathy. And again, with this student, we are building a new portable camera that can be delivered to patients, and they can get screened. Or a lens that we are developing with my former fellow, Dr. Simmons for a better retina imaging and diagnosis, telehealth diagnosis. Again, no, hey, Dr. Joe, let's go to step 4. Even if you have diabetic retinopathy and you are diagnosed, we can help. We can save your vision. Then seek retina care. Because treatment is more than 90% effective in preserving vision, and without treatment in most advanced forms of diabetes, 50% of people can lose their vision. Diabetes progresses orderly from milder forms to more advanced forms, from mild non-proliferative to more severe non-proliferative to proliferative diabetic retinopathy. And then treatment options are different from different stages, and from less invasive to more invasive. So treatment modalities could be like laser. You saw a video, nice picture from Dr. Kuzkanani. Also intraocular injections, as Dr. Uzbahani mentioned. And we have a good repertoire of medications that we can inject in the eye for different indications. So this is a picture. This is right hot from the oven. I operated on this patient yesterday. If I can play it. And then she came with a terrible retinal detachment, bleeding in the eye. Had surgery yesterday, and these pictures are from today. Had a hand motion vision. Was not even able to count fingers, but today, right, one day after surgery, opened the eye. 2200 vision, and she's going to get better. Her vision was saved. We can help. So these are just a few other. If I have time, I'm going to show you a few patient scenarios, different. So this is a 38-year-old male with poorly controlled type 1. Comes with floaters in the left eye. Very benign. It's the symptoms, right? So I just have a few things, floating in front of my eye. But when I examine him, he has all these abnormal vessels growing in the right eye. He has severe diabetic retinopathy. In the left eye, he has new vessels and abnormal vessels growing and pulling on retina. His vision is 20/20. That's why you have to get screening, even though your vision is good and you have minimal symptoms. A magnified view showing all these abnormal vessels, like octopus, arms extended to retina, and they're ready to bleed and pull retina. Fluorescein angiography, I'm gonna skip these. And then this patient got laser treatment, had surgery in one eye because had bleeding, but after a few years, he still maintains 20/20 vision. This is another patient, 57-year-old female with type 2 for 10 years, sudden vision loss in the left eye. You can just obviously see that there is bleeding here, right? So details of right eye has a good vision, left eye has lost vision, but details you cannot see, full of blood. But with good laser, she got her vision back and she has stayed stable. This is this gentleman, a very nice gentleman in a finance field, but he was busy, under stress, COVID time, going through divorce, and all those came with vision loss in both eyes. And again, I'm gonna skip this. This is his vision, 20/250. 20/100. I'm surprised how can he work for last 2-3 months, because when he started, probably started a few months ago, he continued, he never came, but then he comes with this severe vision loss. Even with just one injection, his vision improved a lot to 21/50 for right eye, 20 months, 20/60 left eye, and then after a few injections, his vision got much better. This is a lady with type 1. I was following her and she was good. She had laser treatment. You see in this right eye, both eyes 20/20, right eye some tractions here, retina starting to pull up, but things look good. But then came with vision loss during pregnancy. So this is from before pregnancy. This is during pregnancy. You remember retinal detachment, we lose part of vision. This is what happened for her, starting to detach retina next to the center. Then I operated on her, and then this is 2 months after surgery. Still during pregnancy, retina got fixed, vision is better. This is another patient. This patient actually lived in Chicago for many years, lost vision after accident, thought that this is accident, never went, didn't have insurance, didn't go to doctors, but actually he was bleeding in the eye from diabetes. 5 years he didn't see. The other eye now, it bled in the eye, and he has to come, right? So because one only good seeing eye now cannot see. And then this is after multiple surgeries for him. He still comes after 4 or 5 years with decently good vision. All right, and this is the last one. You saw this picture. This is an engineer or software engineer or something. Again, came with bleeding, but this is just right after surgery. His vision went back to 20/20, and he does fine. And the last step, now we passed all these steps now, but then regardless, there's going to be people with diabetes, with all these laser and losing vision. We do treatment and whatnot, and then last step to preserve vision is rehabilitation and support system. So what I do, and I think most of my colleagues do, we discuss the findings with pictures, with patients' own pictures. They know how severe or serious the condition is, and they seek treatment and they adhere to recommendations. We contact their primary doctors to let them know that this is a severe diabetic retinopathy. They need to check their kidneys, hearts, and all other systems to help us with the good blood sugar control. Educate them about blood pressure, blood sugar, cholesterol, and lipids. Encourage lifestyle modification, and good refractive correction. Right. So at the end of the day, a good glasses is going to help a lot to those who are losing vision, and bad loss of vision. Those who come very late, low vision rehabilitation is essential. So last slide, just key messages. The prevalence of diabetes is increasing worldwide, including us. So is the prevalence of vision loss and blindness due to diabetes. Good blood sugar control, cholesterol, blood pressure, good healthy lifestyle is going to prevent diabetes or delay diabetes and loss of vision from it. Regular screening is going to help with early detection and treatment, appropriate treatment in appropriate time. And then treatments are available: laser, injection, surgeries, and rehabilitation to preserve vision and preserve vision. So this is it. Thank you so much. This is just a reminder. It's not very nicely. You can have this nice better.
Well, first of all, thank you very much, Dr. Nazari, Dr. Kuzikanami, Dr. Ruzbani. You did a really, really great job to really educate all of us about all the eye problems. I want to just interject as a primary care one thing on the things that you said. Lifestyle change is the #1 treatment for not only retinal problem, eye problem, diabetes problem, heart problem, kidney problem, lifestyle change. And you know what is including lifestyle change? Sugar means carbohydrate, not just pure sugar. So every carbohydrate, complex carbohydrate, majority Iranian diet has rice. That's the worst carbohydrate. Particularly it's so delicious and you eat too much of it, and never follow what my father said. Take everything but leader, not whole. That was
Even good Tabriz rice with saffron and
right.
chakayma.
No, rice is getting bad. Because what now we call it beer belly, even for the people who do not really drink beer, is I call it rice belly. Because the fat,
Guilty about it.
the fat here, visceral fat, produce so many active protein that cause micro and macro angiopathies. That's based on your talk.
Thank you so much.
Now we go for a question.
Thank you so much.
Dr. Ruzmani and Dr. Kuzikanani, if you come here, any questions for any one of them? Raise your hand. Okay, I bring the. Okay.
Does blue light cause macular degeneration?
The question is, blue eye cause,
Blue light.
blue light, I'm sorry, cause the AMD or macular degeneration?
Great question. It does not. I mean, what do you mean by blue light?
I mean, there is a rumor that dentists get macular degeneration 10 years ahead of anyone.
I haven't heard of that, any information of that.
I think blue spectrum could be one of the risk factor, but no, I haven't heard about dentists, claim. I don't think so. I agree with
Yeah,
that.
blue light is culprit for many things in the eye, but pure blue light, if you stare at blue light for 30 years, possibly, yes, but we haven't heard anything about dentists being at more risk. Yeah, yes, sir.
But if I also add is that, within the spectrum of light, blue is probably more harmful for retina than red and orange spectrum. So for example, if you want to get sunglasses, don't get blue sunglasses, right? Because it's gonna filter everything out and you are gonna get blue spectrum in the eye. So that could be dangerous. Brownish, darkish, grayish sunglasses are better.
I go to the next, I heard. I'll be back to you.
So for macular degeneration, is there anything on the horizon? It's kind of a sad disease. Anything on the horizon
Yes.
for macular degeneration?
The question is, anything new in the horizon for macular degeneration? Anyone? You want to answer?
I would say for treating wet degeneration, there are new classes of drugs that are being investigated. There's a promising one in clinical trials that may allow many patients to get much less frequent injections. There are other therapies being investigated involving genetic therapies. So there is treatments that are on the way for dry degeneration. There, as Dr. Mihan-mn alluded to in his talk, didn't have a chance to get into them in detail, but there are treatments now available for atrophy. They're not great, but there are some treatments there. So I'll let my colleagues elaborate more.
Yeah, there's a lot going on. Yes, as Dr. Mihan-mn said, for wet part of macular degeneration, we have great treatment these days. I mean, we can dry it out, 95%. That's amazing, but requires multiple or monthly injections or every other month monthly. We try to decrease the burden of the treatment these days. They're working on much longer lasting medication. That's something that we can inject maybe one and done. It's called gene therapy. They're working on it. There are multiple clinical trials. Nothing available right now to the public because there's some side effects and it doesn't work all the time. But I'm pretty sure very soon we are gonna hear more. For dry macular degeneration, there are some injections. We never had any treatment. We cannot cure it again, but those spots of geographic atrophy, they don't pop up overnight. Okay? It's very small. If you expand, small islands get together, big island, like a continent. Yeah, you see right at the center. There are injections can delay those changes, and there's something new called photobiomodulation, so light therapy for that intermediate stage of macular degeneration to prevent it going to advanced stages.
Well, I have a question for Dr. Mihan-mn. You said that if somebody says, "Oh, I have floaters," how quickly we should repair them?
The question is how significant floater is. If somebody complain of floater, what that person should know.
So typically, if someone has new or different flashing lights or floaters, because again, many people have floaters, just baseline. But if suddenly people notice something very markedly new or different, I generally advise my patients that they should come in and call us and get examined. It's not a go to the emergency room thing. So definitely, wait till the next day to call the eye clinic. But typically we get such patients in within a few days or a few weeks. It depends on the symptoms. There are red flags that say these may not just be a regular vitreous detachment. This patient's much more likely to have a retinal tear than a typical vitreous detachment. But I would say typically within a few days or a few weeks is acceptable. I'll see if my colleagues agree.
Absolutely.
Any question? Anyone?
So if someone gets floaters Sunday night, don't go to ED. Wait until Monday morning. Because you're gonna go to ED and then our resident is gonna call us. Jokes aside, there's no use of that. Just Monday.
And now?
Kind of a silly question. We're using a lot of infrared therapy for skin and hair. And although they close the eye, does it affect the eye or not? Like the infrared therapy we use for the skin.
So the question is, does infrared harms the eye? Not as far as I know.
Are you talking about infrared lasers or just?
Not the laser, like the light therapy.
Yeah, I'm not aware of. Unless you're overheating their eye and giving them thermal burns, but I assume you're not something you're talking about.
Yes.
Can anything be done about visual migraine auras, migraine visual organ?
The question is anything that they can done for visual migraine, which is actually common in primary care setting. Anyone?
As ophthalmologists, our role generally is when patients come by is to exclude an ocular pathology. Sometimes visual migraine auras can be very similar to blood vessel occlusions in the eye. They can be very similar to retinal detachment sometimes, the symptoms that patients get. And so our role as eye doctors is basically to exclude an eye origin for the symptoms, and oftentimes we'll tell patients that they have migraines, but for treating the migraines, I generally refer them to the neurologist. I don't have any expertise in how to actually treat those. I'll defer to my colleagues.
Yeah, I think so. So generally, if this is ocular migraine, it's not coming from the eye. We see those, but this is not an eye disease. This is more central disease. Again, but as you just heard, we try to exclude those diseases that can become blinding. So just rule them out and then ask patients to see our neurology colleagues. But my understanding again is that these are small vessel disease. Anything that can stimulate small vessels, can constrict small vessels, may produce ocular migraine. So anything from food and relaxation and whatnot, if we can relax our vessels and our vascular system, probably is helpful.
Any question?
Thank you so much for all very informative lectures. Could you please explain more about photobiomodulation and impact on the treatment of retina or degeneration or whatever?
So repeat the question.
Yeah, Dr. is asking about photobiomodulation. This is something new in the field of retina. They use it in many places, including dentistry. It's new to us. We borrowed this from somewhere else. So it's photobiomodulation. The patient is gets exposed to the machine. It goes under exposure to some specific wavelengths for a specific amount of time, a couple of sessions back to back. And actually it cheers up the mitochondria inside the cells and decreases those, improves that oxidation over there. And the photobiomodulation for macular degeneration, those bumps or drusen we have in the back of the eye, this study shows that they become smaller and flatter. They would go away. So macular degeneration can regress from like intermediate stage to earlier stages. And that was so promising from the clinical trial. That's the only treatment that can improve patient's vision. But it's very new. That was a small clinical trial. The machine is just got to the market, got the FDA approval last year. It's not approved by the insurances yet, they don't pay, but they're working on it. It's pretty new, we'll get more information down the road, but that's very promising because it's like non-invasive type of treatment. It's not a shot that improves vision.
Thank you. Question. So most of the topic that you covered was like when the person has a symptom. So technically when the shit hit the fan, so what to do. But the main question is, what are the early detection as an individual that we can do annually checkups? So I think someone told about OCT that we can do that in our annual checkup. So what are the most important things that as an individual need to focus before like the early detection? Like do we need to do some DNA tests? Do we need to do so if you educate us on that?
Sure. Yes, he's asking about what to do yearly. Should we do some sort of imaging every year? Do we need to do some genetic tests to see if we are at risk or not? Genetic tests are not recommended. Let's say it comes positive for some disease. Most of them, you don't have a treatment to stop it, okay? So it's not basically recommended to do some genetic tests if you don't have any family member with that disease, okay? But if you have a family member who has macular degeneration, we already know that, okay? But looking into the genes, say, hey, you have 20% at risk of this disease and that disease. It's not only one disease, there are like hundreds, okay? It's not just the eye, it's not just the retina. So it's not recommended to do that randomly. But examination is the basic of like the old-fashioned type of examination. You go see your eye doctor, have them to check your eyes. You don't need any of those fancy images, okay? First thing first is examination. Many of these we can figure out just with the exam. We use all of these fancy tests to confirm our diagnosis. And also take your symptoms seriously. If you have a floater, do not ignore it. Dr. Nazir just showed us a patient with a little floater had the worst diabetic retinopathy. If you are losing your vision, if your vision is not as good as before, go see your eye doctor. There's an answer for it. Okay? Take your symptoms seriously. Regular checkups, especially if you're at risk, if you have diabetes, you have a family member with some eye diseases. I think that would be the fundamental.
In one of your slides, I think that was the early symptoms that you showed the OCT that it shows like a small bubble underneath of the surface. So do we need to do OCT for that?
No, I can see that on the exam.
Okay.
As I said, I do the OCT to confirm my diagnosis. Gives me much more information about the details in the eye, because these scans are very sensitive. Sometimes I miss something, gives me more information. But I don't do random OCTs for people on the street to see if someone has bruising or not.
I was just going to add, the American Academy of Ophthalmology has guidelines for how often people need to get their eyes examined. Generally, before age 50 is much less often. Before age 40, I think they say, every 5 to 10 years for, let's say, a 20 or 30-year-old. By age 40, every few years, maybe. Age 50 is when they start recommending annual eye exams. And you're looking for things like early signs of macular degeneration, as well as glaucoma, cataract. There are other diseases that can kind of creep up on you without giving you much symptom warning early on. And of course, you have other systemic diseases if you take certain medications, and there are screening guidelines based on that as well.
Actually, from primary care standpoint, how often we should have eye exam, the US Task Force recommendation is as such that if you have any eye problem, at the time that you notice that, go see the eye doctor, ophthalmologist. If you don't have any risk factor for eye problem, you don't have to go see them, as you said, before age 50. But if you do have risk factor, a major one, as everyone said, diabetes, the US task force recommend yearly exam by ophthalmologists to see if there is any retinopathy due to things. If you do have proteinuria in your urine, which is early detectable things in the course of diabetes and high blood pressure, that's also, you need to have eye exam yearly, because that's also a risk factor for retinopathy. That's from primary primary care standpoint.
Just wanted to add something.
Does it have to be with ophthalmologist or?
What?
It's just.
It doesn't have to be with ophthalmologist, honestly. So you can get your eyes screened and checked with the optometrist or ophthalmologist. But the point is, if there is any reason for referral, you have to ensure that your doctor detects it and then refers you to the proper place. Or to ask if you have diabetes or anything that can be related to your retina, to have a dilated eye exam, because that doesn't happen routinely for all the patients.
So, like considering all of the messages from your slide decks, the key risk factor is the aging. And after 40, 50, that you said is a necessity to do the checkup. So, considering that the longevity and anti-aging is on a rise, so taking some like anti-aging, NAD plus, NMN supplement doesn't have any impact on the vision. Is there any like longevity anti-aging stuff that's gonna slow down the AMD or any study on that?
So you would think so, right? So you would think that if you delay aging or you have less aging, everything that comes with aging is going to be less. We don't have a study to prove it, but these things need studies for 10 years, 15 years, a lot of millions of dollars. We don't have that money or that resources to spend on that. Probably if you think that this is common sense, anything that prevents aging is probably going to help. So that's it. And I wanted to add a question about the genetic testing you just mentioned. And as Dr. Usmani mentioned, we don't need to go and get genetic testing. Back in 2009, when I was a faculty at the Tehran University, I did, I studied, I got a small grant and I studied genes associated with age-related macular degeneration in Iran population. And we had a high rate of ARMS2 and CFH gene that are associated with macular degeneration in Western and Caucasian population. So we have in our genes that are associated with macular degeneration. Even though we don't have to go get that, just knowing that we are by nature prone to that. And then if you have family members, father, mother, older brother, uncle with with macular degeneration, and you want to absolutely know your risk, 23andMe includes these two genes. So you can get, if you are getting this for any other reason, you can look at the ARMS2 and CFH genes. Yes?
I think we should add the pre-diabetes to the list of eye exam and retinal check, because many micro and macrovascular side effects starts before the full-blown diabetes.
The question is, if someone has pre-diabetic criteria, should we have eye exam?
Probably okay, but then if we give this recommendation, it has implications on hundreds of millions of people, right? So we just adding a pre-diabetes to screening, but retina screening, we probably add hundreds of millions to already broken medical system in this country or everywhere in the world, right? But then you're just having, so the recommendation is type 2 diabetes, 5 years after diagnosis. So that's the recommendation by medical association, by American Academy of Ophthalmology and other systems. But let's say you have pre-diabetes, you are going to get your eyes checked for glasses, for cataract, for anything else. There is nothing wrong with your eyes being checked for diabetes, and you should ask probably your eye doctor to do that.
And in this,
in the same vein with the idea that many people don't have access to eye care around the world, even in the US, people can't easily schedule with eye doctors. There's a concept of mainly focusing on detecting vision-threatening diabetic retinopathy. Because the reality is if you have very mild diabetic retinopathy, no edema, a few microaneurysms here and there, no treatment is necessary, we're just gonna see you again in a year anyway. And so, detecting a few mild changes with prediabetes may be worthwhile to note, but it's not gonna change your clinical care, as Dr. Mazzari was essentially saying.
Well, and I'm sure that someone will agree with me that ChatGPT 3, you have a question, ask ChatGPT. I'm not advertising for it. So right now it's free app. Huh? Yeah, it came now, but even the earlier ChatGPT 3 have answered to your question.
Dr. Mazzari, you mentioned about machine, AI-based machine that you guys use for retinal. How much accurate are those machines and how much you guys trust that?
So we don't use, this has been approved and being used more and more across the country. I think based on the studies showing their detection rate, they have very high detection rate. I trust them. So if a patient comes to me, I think what we are going is that we are going to install eye cameras in medical primary care offices across the country, across the world, and that's a really good thing to happen. So let's say someone from Bemidji cannot come to eye doctor for months and years. How good that could be that there is a camera there, looks at those with diabetes, hundreds of them, and then say that you have diabetes, you have to go to Minneapolis to get your eye care. So they are reliable if when they get widespread. We don't have those, but based on the data, I think we can rely on those, and we can, collectively we can benefit from those.
Are the information in those machines are local or they are actually connected to a server and they do more data analysis on the server side at the same time?
As far as I know, they are doing that as a central data center. So they have thousands and thousands of images. They are being trained for those. And then if there is diabetic retinopathy or any other disease, or not any other disease, diabetic retinopathy, they can make a diagnosis, or at least can red flag a picture saying you need to be seen by a human.
And the last one, do you see the future of AI in your business, a lot more than?
Yeah, absolutely. Absolutely. And as I said, I think this is an absolutely wonderful thing to happen because so many people don't have access to us. This may people have access to medical care better and better. So many people come to me, they don't have anything, they don't need to come to me. AI can make it and exclude them, say that, hey, you don't need to go to a retina specialist. Let his time be spent with more serious issues.
Right. Thank you.
Well, yes, go ahead.
I have a question about different climate, cold and hot, it affects your macular degeneration or not?
You get it?
Yes.
So Dr. Ruzvahani has been in Florida and here in Minneapolis. So,
I can answer that. But the thing is that people from Minnesota, they moved to Florida, so they're the same people over there.
Yes, that's also.
I'm not aware of anything like that. The climate can affect your macular degeneration, but your genes and like people from Eastern or Northeastern Europe and people with blue eyes, they're more at risk of macular degeneration. You already know that, but the climate.
I haven't heard of it.
Okay.
Thank you.
But more tequilas spent in Florida, maybe that.
Dr. Rosmani, in one of your slides, I saw a RED2 bottle.
Yes.
The main basically protein in there is lutein. And reviewed that study, whether how effective is that of either treatment or prevention of macular degeneration. Can you comment on that a little bit more?
Yes, there are a bunch of like vitamins and some other things in those A-rich too or preservation like vitamin E, C, lutein, and zeaxanthin. Lutein and zeaxanthin, these are antioxidants. And we have a lot of those on those vegetables. Why is kale is good for macular degeneration, kale, broccoli, spinach? They have a lot of lutein and zeaxanthin. And the clinical trial is called A-rich2. This is one of the biggest clinical trials in the history of eye diseases called age-related eye diseases study. They looked into people with macular degeneration, without macular degeneration, followed them for many years. And the study showed that this combination of vitamins and lutein and zeaxanthin can delay getting from moderate stage of macular degeneration to the wet macular degeneration.
That's what I wanted.
But again, we do not recommend someone who doesn't have macular degeneration go get it from Costco because there's a good deal on it. And I want to get something for my
The money can be better spent on research and rightly.
Okay, any other question? Well, I want to really, really thank you, all three of you guys, for spending your time, educate all of us, and I hope that we can have the chance to see you at least another year or another 2 months or more up to date knowledge. And I want to also thank you all the members, and I'm not going to name you now because then I forget, who really keep Mihan alive. Thank you, thank you, thank you very much. There is a lot of things that we Iranian know, and we have to share that with each other. Thank you.
Cameraman, thank you. I got it. Yeah, right here.
Thank you.
Thank you all. I have a question for you. So, great. I was just focused because I knew about London. I like your yeah. Oh, yes. Yes, the question. So, about like fiber protection and
When I was there, like, he goes like, I know it's like, I know it's like, when I was there, I was supposed to do this, like, I swam in the water. Saw a guy in my life. I know it's okay. Oh yeah, I mean, no, I don't change it every exercise. But I like